Welcome to Best Practices that Yield Clinical and Surgical Success. This is a CME presentation by the American Association of Colleges of Podiatric Medicine's Council of Teaching Hospitals. Tonight's speaker is Dr. Kittra Owens. Dr. Owens received her Bachelor and Master of Science degrees from Tuskegee University and her Doctor of Podiatric Medicine from Temple University. Immediately upon completing her residency at Oakwood Healthcare System in Dearborn, Michigan, she was commissioned as a Navy officer. Her career as a podiatric doctor and surgeon began at Naval Hospital Camp Lejeune in North Carolina, and throughout her 8 years in the Navy, she served in many global locations, including Japan, Afghanistan, and Cuba. Upon completing her active duty obligation as a lieutenant commander, Owens began working for VA Southern Nevada Healthcare System in their Department of Veteran Affairs in 2015. She currently serves as Section Chief of Podiatry, Foot and Ankle Surgery, GME Site Coordinator for Foot and Ankle Surgery, and is a clinical professor at UNLV School of Medicine. Dr. Owens is board certified by ABPM and ABFAS. Dr. Owens?
And I hope everyone's able to see that now. Okay. As was stated, I'm Dr. Kittra Owens. My role here at the Las Vegas VA has kept me quite busy. I'm coming to you guys live from my clinic evaluation room. This was not how I thought the evening would proceed, but here we all are together. I think my role as the GME site director is even more demanding because it's an impressionable role. Currently at our facility, there are 3 affiliated programs that rotate through my clinic. Family medicine, we have a sports medicine and urgent care residents who plan to matriculate and do some sort of fellowship or practice afterwards. I have the internal medicine residents from UNLV that come through. Physical therapy students, my 2 from Boston University and Emory. My PT student just left to join the Minnesota Vikings next month. Also, there are chiropractic students, advanced nurse practitioner students, and in the fall, we'll have UNLV endocrinology fellows. Currently, I'm coordinating with the San Francisco VA for potential residents to come through here as well. So we are a busy program, and I'm glad to have involvement with the graduate medical education program. I have no financial disclosures to convey, but I'll start by saying this. As our practices and residency programs begin to get their footing and we are sort of setting our paths forward coming out of this pandemic, we cannot underestimate the impact that this pandemic has had on each of us. I went back and forth when approaching this topic today, and from what viewpoint I would hope that this information was received. And I hope that it serves to remind students and residents simply of what's important. What are the best practices that we need to instill in our residents to ensure that they develop and to ensure their long-term success? 2020 was also what I refer to as the conscious awakening. It was compounded by visuals of social injustice and healthcare disparities and racism and politics. And often we attempt to avoid these topics in discussions in the workplace to eliminate confrontation or differences of opinion. But I feel that if we gently guide this dialogue, especially subject matter on how cultural diversity adds to the residency experience, more can actually be understood. From a program director standpoint, and even from an attending physician standpoint, residents are watching our mark. Every day we are held accountable for them. Every day is a day to develop and cultivate them into leaders. We'll also explore what we're able to do to manifest that as well during this presentation. I've always been an athlete. Anyone who knows me knows I'm competitive, and I'm not okay with just being good. I want to be the best. And I went to college on an athletic scholarship, and as a 5'2" freshman point guard, I learned a valuable lesson. I learned the saying that practice makes perfect is actually a misconception. So you can practice the wrong thing over and over and be unsuccessful at your craft. It's actually perfect practice that makes perfect. As physicians and as surgeons, our responsibility to our residents is just to make sure they don't have to strive for perfection, but just to make sure that we know and they know that mediocre is just not okay. Our responsibility as the trainer, as the educator, as the attending is to encourage them to be better than what they imagine for themselves. And we do that through preparation. We do that by developing consistent routines. We help our residents to understand how to manage complex and difficult situations. And lastly, we teach them why cultural competence is important. Now, based on how your clinic is set up or how your practice is set up, preparation may look a few different ways. But when the residents come through my particular clinic, before they even encounter the patient, before they go into the room, I encourage them to understand why the patient was referred to us in the first place. Now, in the VA system, that's simple. We look up a referral, we see if it's the primary care who referred them or a specialist that referred them over. And a lot of times, some information is there. I also encourage the residents to do a pre-screen of the radiographs. Find what's normal, look at any abnormalities. The radiograph doesn't mean come up with a conclusion or an ending diagnosis. The radiograph plus the reason for a referral may help the resident come up with a preliminary assessment. In the military, this is something that we simply refer to as reconnaissance. Sometimes the preliminary information may be available, sometimes it may not be. In surgery, preparation takes on a different meaning. The resident should, the night before, make sure that they're aware of the cases on doc or on the docket for the day. Understand why that particular procedure was chosen for the patient. Think about if there are any alternative or plain old procedures that could have been done as opposed to the one that was selected. Know what could be the potential pitfalls in the surgery and what to do if complications arise in the operating room. What would be a plan B, plan C? I think that each resident should have a defined role and responsibility on the day of surgery. Whether that resident understands that they're simply going to be retracting, if they're expected to perform closure, if they're simply given the local injection. We have an obligation to prepare them for both the clinic and surgical setting. Now, for many of us, this is intuitive. However, with some residents, I've found that there is a preoccupation with seeing the patient, going through the examination, and then moving on to the next patient. And what this does is it devalues the entire patient experience. The knowledge base of a resident can be spot on, but the delivery can be subpar. There are routine or simple routines that can convert a mediocre experience to an exceptional patient encounter, and it starts by simple practices. I encourage all the residents that when they walk into the room, the first impression is important. Smile when you enter the room. Look at the patient, address them by name. Depending on the generation, some patients may prefer to be identified by their first name. Some may be, prefer to be identified by their last name. Whatever it be, adjust fire if necessary. I encourage residents to sit as opposed to stand over the patients. Talk face to face if there's time to sit. Spend at least the first 2 minutes simply listening to the patient. Also, it's important that residents learn to set realistic expectations. Often patients come in and they have a multitude of concerns. Teach the resident to focus the patient in on the number 1 or 2 things of concern. Set forth conservative and surgical treatment options. And once a diagnosis is established, have the patient repeat the diagnosis. It confirms that they are actually engaged in the decision making. One key thing that I encourage most residents to do is to document a specific fact about the patient and use that as a segue for the next visit. And most of the time that fact is obtained in that first 2 minutes that's spent listening. Now, We have similar routines for the operating room, and routines can positively or negatively impact the flow of the OR day. Many of us know that. A resident should come into the pre-op holding area looking ready for surgery, not as if they just rolled out of bed. Say good morning if time is available to the patient's family. Let them know that as soon as the case is over, they'll be given information. Be courteous and nice to the ancillary support staff. I learned a long time ago that you can make a best friend out of an OR nurse or worst enemy. One of the things that we practice consistently here in our operating room is the OR huddle. That's the pre-assembly where everyone in the operating room understands the reason the patient is coming to the operating table. We validate if the instruments are there. We talk about any risk or complications, allergies. All the information is laid out on the table, and we do that to minimize the risk of error. Residents at that time can be preparing the local anesthetic. They should be comfortable with understanding how patients are positioned. But I think most importantly as well, residents need to have a comprehensive understanding of procedure time management based on the plan of the day. A bunion should not be boarded for 3 hours. Keeping time and pacing time, making sure that you get that patient on and off the table appropriately. After the procedure, the attending should perform a debrief with the resident. Lock in the promising things that were done during the operating room time. Also note some of the pitfalls that could have taken place and propose corrective measures for the resident. Allow the resident to notify the family and speak to the patient about outcomes. That way they become comfortable with this process as they transition from residency to attending status. Now, I think the highlight of a resident is when the torch is passed, when they start performing those C-level cases or skin-to-skin cases. This is actually where the academic and the applied skills come hand in hand. You know, just as we prepare a resident to stabilize and fixate a fracture, we also have to prepare residents for suboptimal outcomes. There must be continuity in the training process. I mean, we teach them to work up the patient, to exhaust conservative measures. We teach them how to perform the procedure, but also residents have to have exposure on evaluating the patients postoperatively to see if actually what was performed surgically worked. I have encountered young physicians that are in their first to third years out of their surgical residency. And sometimes they have no clue of how to manage the post-op course. Oftentimes it's very shocking to see, and it leads me to believe that during residency, maybe they cut a little bit more than had adequate patient follow-up. To see a young physician disheveled or impatient or accusatory of wrongdoing by the patient, this is a great way to deteriorate the patient-physician working relationship. You know, I tell young physicians, I tell residents, you know, when complications occur, distancing oneself is not good practice. This is the time to stay engaged. This is the time to put the extra effort forward. This is the time to reassure the patient that even though there's a complication, there is a plan in place. Doing this may decrease the likelihood of litigation as well as patient mistrust. Now, there are going to be some challenging patients. You know, when I see patients coming in and I see them fully weight bearing on what should be a non-weight bearing cast, and they're promising me up and down that they didn't put any pressure on it, I actually get relief for a minute. I'm actually trusting that the patient didn't walk on the cast until I take the cast off and see the entire foot macerated with a green color and odor coming from the bottom of the foot. So we have to prepare our residents for those challenging patients. And these are patients who may have, you know, underlying mental health disorders. They may have anxiety. They may be irritable, depression. We may even encounter patients that have drug-seeking behavior, excessive requests for attention from the physician at hand. Some patients may be verbally abusive. These are the hard knocks of medicine. and it comes with the territory. But preparing the resident to cope with these difficult patients is key. Showing the resident how to be tolerant, how to be a good listener, not only a good listener, but an active listener. Sometimes the resident may choose to disclose something personal to connect or de-escalate the situation with the patient. Sometimes humor may be the go-to coping mechanism for complex situations. Whatever it is, allow the resident the opportunity to work through those challenges. Residents may encounter patients with multiple deformities. I think it's imperative that we teach residents if these should be procedures that are one and done, or if these should be procedures that are staged. A few years ago, I held up an x-ray to a podiatry resident, and the x-ray was of a simple midfoot collapse with a rocker bottom deformity. The patient had a wound under the bottom. Of course, it was a Charcot foot. In addition, there was a bunion, there was a hammer toe, posterior tibialis tendon dysfunction, as well as equinus. I mean, the patient was excited. The patient saw, oh my goodness, the level of complexity and the involvement that I get to have with the patient. Now, I did have to break it to the patient that this was, I did have to break it to the resident that this was also a patient that was on dialysis, that had a hemoglobin A1C of 9, that had COPD, hypertension, and a history of a DVT. I mean, that smile quickly turned into a frown. And having a resident understand that it's just not about the multiple deformities or the procedures that can be tackled, but having the patient see the clear picture of how the comorbidities contribute to the procedures that can be planned is key. Being able to put that patient safely on the table and getting that patient safely off the table is a prime way to decrease significant post-op complications. One of my mottos is broadening the lens of the resident beyond the surgical field and having them take a look at the entire perioperative course. I am a very nostalgic and retrospective person. And, when I sit back and think about things of the past, it helps me to navigate future occurrences. In May of 2020, let's go back. In March of 2020, my hospital admitted the first COVID patient in the state of Nevada. From this point, we determined that we would deliver healthcare based on 4 principles. And during that pandemic, we focused on 4 main things: emergency preparedness, how we were going to move information technology forward to still deliver, focused patient-centered care. We talked about high reliable organizations, and in doing so, how to make sure that we were not compromising patient safety. And then there was a concern of ensuring that our facility was culturally competent. Now, residents during this time were instantly promoted to attendings. They became colleagues as we needed the manpower for the fight. One team, one fight against the COVID pandemic. But as we peeled back the layers, not just with the residents, but with colleagues and support staff and patients, we saw a tremendous need to do a better job at communicating and understanding each other. Now, Nunez describes as definition of cultural competency as the ability of healthcare providers to interact with patients who are different than themselves. If we take a bigger look at that, we can take out healthcare providers and we can say cultural competency is the ability of support staff to interact with patients differently. It's, the other ancillary services, ability to interact with patients who are different. As our world expands and people travel from one part of the earth to the other, this leads to profound opportunities to build impactful relationships. In an article in 1997, Peterson and his colleagues define 4 elements of cultural competency. Most of us think of cultural competency as just making sure we recognize the social and cultural and linguistic needs of patients, but you know, there's more involved in it. And it starts with awareness. And this is taking a closer look at individual beliefs. And not only individual beliefs, but historical prejudices and stereotypes that actually create barriers for learning and personal development. And this can be difficult. One's attitude, in order to develop completeness, one has to be open to viewing and receiving different opinions. And often I tell residents that being open doesn't mean that you have to change your values. The more you know, the likely there may be misunderstandings. And this was very applicable to the pandemic when we talk about vaccine hesitance. At our facility, we noticed that many minorities were hesitant to receive the COVID vaccine, and I understood why, being an alumni of Tuskegee University myself. There was the familiarity with the Tuskegee experience and the lack of trust in the healthcare system when it came to minorities being vaccinated. Just bringing the entire team into the fold to understand that took away the judgment and took away the biasness. And these are the skills that we have to apply to our learning setting. Bottom line up front is, if there's less biasness, we can find ways to minimize misunderstandings and improve the overall outcomes of the way we render healthcare. And maybe not just healthcare, improve the outcomes of way we live through life. About 6 months ago, I was invited to join this sort of closed speaking environment where there were minority attendings and minority residents that had the opportunity to voice concerns. There were no names mentioned. There were no hospital programs mentioned, just an open platform. And an African-American young lady had the opportunity to tell her story. And she mentioned being on hospital rounds and being the only minority on the service, walking into the patient room of a Caucasian 60, maybe mid 67-year-old gentleman who stated that he did not want an African-American in the room or to be a part of his healthcare experience. The attending that was on rounds asked the young lady to step out of the room. And when the student voiced this, concern immediately, I was empathetic to her experience. I was sad that this happened, but I was also empathetic because this is not the first time I've heard a story of such. I can remember myself as a resident having similar experiences. I informed the student to not place judgment on her attending. I informed the student that maybe the attending was caught off guard. Maybe the attending didn't know how to respond to the patient. Maybe the attending simply thought that the patient had the opportunity to express their rights. But in that moment, the act of telling the resident to go out of the room and not participate in the patient encounter was not right. Often our actions or our inactions affect those, and they can indirectly, in fact, affect others that are involved. It would have been appropriate of the attending to educate the patient that African Americans, Hispanic Americans, Asian Americans, Native Americans, all races and ethnicities are valued in the program. And that's what we as program directors, attendings, trainers, we have to be the voice that supersedes everything else and speak up on behalf of our residents and students. African Americans and Hispanic populations are disproportionate entities when it comes to healthcare. They have higher diabetes rates, higher percentages of obesity, cancer, and in evidence-based literature, Cooper and Patrick made a statement that states, patients with race concordant doctors report that they are better able to participate in the decision-making of their doctors. And I believe this statement to be true only because minority physicians are more likely to simply connect with minority patients because of their shared experiences. But it does not mean that the bridge can't be gapped. When deficits are noticed, how does a healthcare entity rectify those deficits? That's done by recruiting and retaining minority staff. It's done by maybe locating or even co-locating clinics that are accessible to certain populations, maybe populations that have to take public transportation to get there, maybe providing interpreters or those who may speak alternative languages or second languages to assist with the patient encounter, expanding clinic hours, especially for patients who don't have flexible hours that may be able to leave a job and come to an appointment. And not only just providing interpreter skills, but going above and beyond. The receptionist at the front desk may be bilingual, or having written material that's available for patients so that there's a clear understanding of expectations. Cultural competency transcends beyond borders. I often share with my residents, and especially residents who are in programs that take humanitarian missions. I think this is important. Within the United States, there is what I call the way of westernized medicine. There's a way that we do things. However, abroad, we also have to be respective of other cultures. When I deployed to Afghanistan, and you can see in this picture, not only am I the only minority in the room, I am the only woman in the room. I did not feel that it was culturally appropriate with a group of men who generally do not give women a voice to exert my opinion and demand a space in the game. Often when we were conducting hospital rounds, the men walked in front and I respectfully walked behind as it was the cultural norm in that area. However, after proving the respect for the culture, for those that I worked with, understanding the barriers and how to mitigate that, that perspective actually changed. And the more I listened, the more I learned, the more I was able to dialogue, the more when I was called upon to teach, they were now willing, my Afghan counterparts were now willing to be led by me based on the initial respect that was shown for the culture. So I encourage residents that if you are a part of programs that go beyond borders and take humanitarian missions and are doing gracious things beyond the U.S., also be respectful of cultural norms outside of the U.S. Now, diversity is an extension of cultural competency. When it comes to diversity, residency programs that choose to select residents based on various ages, sexual orientation, various races, religion. This simply exposes everyone to various backgrounds that allows people to share experiences. And from that, even non-minorities benefit. I mean, having depth and different ideas can broaden the standard operating procedures and processes that ensure that all perspectives have been considered. Diversity from a patient standpoint, it shows that the entity values inclusivity as well as trust. Even patients of a particular race, if they go to a particular practice or they're being treated by a resident through a teaching program, even if they see a doctor that's not of their ethnicity or their own heritage, if they recognize that there's diversity in the residency program, they're more apt to believe that cultural competency is taking place in the respected group. From the program standpoint, diversity is important because it's attractive in the marketplace. Having a spectrum of residents that embrace all nationalities, ethnicities, age, sexual orientations, religion. It's simply a reflection of the community of the patients that it serves. Patient satisfaction, when patient satisfaction is higher, it may also yield higher financial reward. I wanted to understand how the matriculation looked as far as students coming into the field of podiatric medicine through matriculation over the next 4 years. The AACPM has great data, and one of the charts shows that our profession is growing. However, there's still a large difference in the number of African Americans and Hispanic, as well as Native Americans and those of American Indian and Alaskan heritage. Those numbers are still quite low to those of the majority. I am aware of pipeline programs and mentoring networks that really help and assist with this recruiting effort. And when our programs are diversified, if there is a diversified student pipeline, then it also proves to be a diversified residency pipeline. I champion each residency program to take a look at how diversified their program is. Take a look and see if it even lacks diversity. And if it does lack diversity, is it a recruitment issue or is it an exclusion issue? Active exclusion, that simply is a design that looks like maybe this particular resident won't fit our model. This particular resident is different from what we're normally used to accepting. This particular resident may have a hard time adjusting. That's what active exclusion looks like. Passive exclusion is when there may not be the attractants for a resident to come to the program, such as there are not a lot of women mentors or women attendings. There may be a minimal level of research engagement. When a program looks to diversify their residency base, when they look to broaden their recruitment base, and whatever that is, it shouldn't just be on recruiting. From day one, retention actually begins with the recruiting effort. Retention of residents that are brought in to help diversify the scope should be focused on giving that resident a mentor to show the commitment that the institution has for the ongoing and mutual relationship. I read an article a while back about the previous chair of orthopedics at Johns Hopkins, and this chair noted that the orthopedic program was saturated with men, and there was no specific policy, no specific quota, but consideration was given to improving diversity through the selection of the interviewers, or interviewees, I should say. This led to an increase from 4% of their residents being women to about 20%. And what was noted out of that was once there was a greater visibility of women in the orthopedic residency program, it led to more minority faculty actually being hired. It led to more women actually seeking the orthopedic program. It also led to more women and minorities moving over to leadership positions, further diversifying what the program looked like. Now, when we look at these three labels on the screen, Nike, Wheaties, Allstate, these are corporate companies that many of us are very well versed in. We look at Nike and we attribute their brand to being, just do it. We look at Wheaties and we see the brand of just being the breakfast of champions. And Allstate, that whole tagline about you're in good hands with Allstate. These are classic images, and we have an association with those images of being exceptional. While branding is a part that establishes reputation, Chappelle and colleagues also noted that there is a way to brand your residency program. I think the key thing is defining the residency program, and it starts by identifying the brand identity. And this is established through the internal and external stakeholders. What is the mission of the residency program? What is the residency program value? What makes this program different from the next? Is there an institutional affiliation? Is there local community involvement? The second tier to looking at a program to make and making sure that the brand fits what's trying to be represented, is the brand image. And oftentimes the brand image may be independent of the brand identity. A program may not even be aware of the brand image, or it may be an image that they may not want to be associated with. And so oftentimes too, this may be, what students think about the program in online forums or chat or social media. That would be perceived as the brand image. Brand positioning is a way to align the image and the identity to ensure that the stakeholders, both those internally and externally, are reflecting exactly what the institution wants. So for an example, if a residency program is in an undeserved area or helping out with an undeserved population, and that adds value to services performed in disadvantaged communities, then this aligns the brand identity with the brand image, meaning that it may show that there is diversity with the program where prior that may not have been conveyed as well. The brand experience is often what's thought of by the externs, the residents, the applicants that come through the program. And at the end, the program should take a seat back and do an evaluation, and that's referred to as a brand audit. Look at the strengths, the weaknesses, and any opportunities to improve the overall program. Your brand will actually be the thing that shapes and molds the resident. Your brand will be the tagline that the resident is associated when the program name comes up. I love the saying by Vince Lombardi, which is, leaders aren't born, they are made, and they are made just like anything else through hard work. And we must recognize that our residents are in leadership roles every single day. We must recognize that we place our residents at the forefront of making care plans for patients. We empower our residents to supervise and teach junior residents and embrace students that are rotating through. We teach our residents to not be afraid to step out and cross the line and talk to the vascular team or talk to the internal medicine team. Our chief residents are doing an exceptional job in making sure that what's reflected on behalf of the attending goes forward, and that goes forward with action. The more we give our residents responsibility, the more we inspire confidence, the more we help to build and craft their communication skills as well as their emotional intelligence. If the residency programs are not focused on various leadership tracks, I employ a few to be considered, such as when residents leave, not only will they become attendings, but it is the hope of most teachers and program directors that they also give back to the profession, whether the resident himself becomes a part of that teaching experience, whether the resident himself become involved on a more global level with healthcare policy, or looking at business models or best practices, or doing research, steering the resident to something above and beyond just surgery and medicine, especially those who have a strong desire to move forward in the profession on another track. And whether that track is, getting involved in the state components, engaging in the Young Physicians Leadership Symposium, presenting at ACFAS or APMA conferences, all of these opportunity helps to cultivate leaders and their contribution to the profession. So in summary, when we think about how we craft and develop and mold our residents, we should consider how best to prepare them, how to give them consistent routines to move forward, not only in their day-to-day now, but routines they can bank on that are reproducible in their practice. It is our responsibility to ensure that residents are comfortable dealing with complex situations. We may not be able to lay every one of those opportunities out, but we should gift them with the ability to get through some basics. Bringing cultural competency and diversity, allowing residents to have the exposure to colleagues who look and sound a little different than them may also broaden their horizon. So the first time they encounter that is not necessarily with the patient. Diversity is a win-win for the patient, the resident, and the program. And again, taking a step back from the residency standpoint and diving into the program, looking at the branding framework. What are you offering to potential residents coming on board? And is that brand what you want to go forward? You know, one of my sayings, and it is my original thought, the goal of residency training and the goal of even teaching, especially our podiatric students, you know, our hope is to produce excellent podiatric physicians, to produce competent podiatric surgeons, and exceptional leaders to secure the future of our profession. I thank you for your time, and again, it has been my pleasure and honor.